Hello friends, in this video I am going to talk about diabetic ketoacidosis in pregnancy, and as usual it is just a case-based discussion and we will try to connect the threads and walk along this discussion. Let us see this case: a 32-year-old female priming at 34 weeks of gestation with type 1 diabetes who was on insulin glargine of 20 units basal and 6 units of mixture before meals presents with altered sensorium, pain, abdomen, and vomiting. She had frequent pain abdomen for the last 3-4 days, and at the on presentation at the time she has a blood pressure of 120/74, heart rate of 85, a saturation of 97% on room air, but the urine dipstick shows ketone results is 3 plus and the glucose is also 3 plus. The blood glucose is 200 milligram per deciliter, the pH is 7.25, potassium is 5.9, and bicarb is 12.5. The patient was drowsy, abdomen was soft, the funnel level was at 32 weeks, the uterus was lax, and bilateral swelling in the limbs was limited to the ankles. The vaginal examination, cervix was closed. There was no precipitating risk factor which could be identified. And on fetal monitoring, the fetal cardiotopography showed a baseline FHR of 160 beats per minute with reduced variability, unprovoked deceleration, and no uterine activity. Now, the question is, how do you diagnose DKA in pregnancy, like in this case? If we look into the diagnosis of DKA as such, according to the American Diabetes Association, we find that there are 5 set of criteria. One is that the glucose, which should be more than 250, the arterial or venous pH should be less than 7.3, bicarb should be less than 15, the calculated anion gap should be more than 12, and either ketonemia or ketonuria should be present. Now, in case of pregnancy, all the criteria remains the same, save the glucose level, because pregnant patients can go into diabetic ketoacidosis even at a lesser blood glucose level, and hence this criteria is chosen as less than 200 milligram per deciliter. According to the Joint British Diabetic Society, up to 1/3 of the patients can have DKA at less than 200 milligram per deciliter of blood glucose, and they use a lower threshold, which is 11 millimoles per liter, which corresponds to a level of 198 milligram per deciliter for diagnosis. So we keep it at 200. So this is the only difference. In terms of resolution, however, there is no difference between a pregnant DKA and a non-pregnant DKA. And whenever this gets reversed, the arterial blood or venous pH, the bicarb exceeds 15, the calculated anion gap becomes less than 12, the ketonemia becomes less than 0.3 millimoles per liter, and the ketonuria becomes absent, and the glucose level falls below 200, it is considered as a resolution. Therefore, one thing has to be remembered thoroughly is that the diagnosis of DKA during pregnancy should not be delayed based on the absence of hyperglycemia if there is a clinical suspicion for DKA. So what are the risk factors for DKA in pregnancy? The common risk factors are nausea and vomiting of pregnancy or hyperemesis gravidarum with dehydration, poor diabetic control due to non-compliance with medications or diet, infections of any form like the UTI, URI, or other viral illnesses, diabetic gastroparesis, undiagnosed diabetes if the patient is not known diabetic previously and may goes right into DKA. Insulin pump failure is a condition which has been found to be noted of more importance in the US and UK, many studies, if the patient has been on US insulin pump and pump failure, although it's as a risk factor varies across the populations. Use of beta sympathomimetic agents, particularly tarbutaline, has been associated with it. Antenatal corticosteroid administration for fetal lung maturity, etc., has been found to be a risk factor too. So of all the beta sympathomimetic and agents and corticosteroids, they are on the rise, they are iatrogenic, and they should be avoided during DKA or should be used with caution in patients who are known to be diabetic and are during pregnancy. If you try to look into the diabetic ketoacidosis versus pregnant diabetic ketoacidosis versus non-pregnant diabetic ketoacidosis, you can look into this diagram. The A part reflects the non-pregnant DKA. The B part reflects the pregnancy in associated DKA. And you can see that in pregnancy-associated DKA, there is less insulin deficit or resistance. The glucose utilization is preserved. And despite utilization of glucose utilization is preserved, the patient has almost same of amount of neoglucogenesis. Neoglucogenesis is not much altered, but there is rise in glycosuria and increased ketogenesis. And in contrast, in non-pregnant DKA, you find that there is increase in gluconeogenesis, increase in glycogenolysis with a reduced ketogenesis. And this pregnancy, there can be euglycemia, there can be glycogenolysis and ketonemia, whereas in cases of non-pregnancy DKA, you find hyperglycemia more often. You rarely find euglycemia. Although euglycemic DKA is an separate entity altogether, which can manifest even in non-pregnant DKA, but it is much, much, much rare. So this implies that pregnant individuals are prone to entering a starvation state more readily than their non-pregnant counterpart if DKA is considered. So what are the characteristic clinical findings in DKA with pregnancy? If you look into the clinical features, we can see that some of the features are more common. Abdominal pain can be severe and even mimic preterm labor or an acute abdomen. There are multiple theories which explains this, particularly expansion of the hepatic capsule, the bowel hypomotility and bowel ischemia, but it resolves rapidly with the improvement in the metabolic acidosis. Altered mental status is common because of cerebral hypoperfusion, decreased cerebral glucose and oxygen metabolism, acidosis, hyperosmolarity, and also the direct toxic effect of the ketone bodies. And as I said, that they are more likely to enter into the stage of starvation more readily. So this becomes common. And there are some other presenting features which can be more common, like hypotension, tachycardia, signs of hypovolemia, weakness, Kussmaul breathing, etc. So a clinical assessment, a finger prick and urine dip for ketones can be done and should be done in patients with high clinical suspicion, and treatment should not be withheld while awaiting laboratory confirmation. What are the four main principles of management? The four main principles of management include lowering blood glucose, correcting the fluid deficit, correcting potassium, and correcting acidosis. Laboratory assessments should be repeated every 1 to 2 hours until the DKA is resolved. And this includes blood gases, blood glucose, serum electrolytes, and anion gap. The venous blood glucose are an acceptable alternative to arterial blood gases, if it is easier to collect. But you have to remember that venous pH and bicarbonate correlate with ABG values in DKA, while the venous pH being around 0.02 to 0.15 lower than the arterial pH, while the venous bicarb is around 1.88 milliequivalents per liter higher than the arterial bicarbonate. So depending on the resources and expertise available, admission into the patient in the either ICU or into the HDU or transfer to a higher facility for adequate level of care may be considered. Now, regarding the fluid, sorry, deficit first, initially the patients should receive 1 to 2 liter of IV bolus followed by a continuous rate of 150 to 250 ml per hour. Additional boluses of 0.5 to 1 liter are guided in order to maintain a goal of urine output of at least 0.5 mils per kg per hour. There are dynamic measures like pulse pressure variation, passive leg raising, which passive leg raising may be difficult in these patients, but unless it is early pregnancy. But there are dynamic measures, including sonographic assessment of the IVSA, which can be useful and can be used to assess volume status and adequacy of volume resuscitation. Traditionally, normal saline has been used for volume replacement. Once the blood glucose comes below 200, 5% dextrose should be added. In non-pregnant adults with DKA, balanced crystalloids were found to be associated with faster DKA resolution, shorter time to insulin discontinuation, and less frequent hypokalemia. But since this has not been validated in pregnant patients, we cannot infer the same in them. After 8 hours, the infusion rate may be decreased to 125 mils per hour. if the urine output is maintained above 0.5 mils per kg per hour. Now, insulin should be initiated at a dose of 0.1 units per kg bolus, followed by a continuous rate of 0.1 units per kg per hour. If the blood glucose does not decrease by at least 50 milligram per deciliter after 1 hour, you have to check the tubing and the IV access and double the infusion rate after the flow is ensured that there are no technical issues. The process is to be repeated every hour till the blood glucose is declining steadily. When the blood glucose approaches 200 milligram per deciliter, add D5 to the IV solution and also reduce the insulin rate to 0.05 units per kg per hour. Continue the insulin infusion until bicarbonate and anion gap normalize and blood glucose is stable at 150 to 200 milligram per deciliter. When the patient is able to tolerate orally and DKA has been corrected, ambulatory insulin dosing may be reinitiated. IV lines should always be primed with about 30 ml of insulin solution to saturate the insulin absorption to the plastic tubing. Correction of the potassium abnormalities is very important because serum potassium has to be maintained at 4 to 5 milliequivalents per liter and should be monitored at least every 2 hours. If the serum potassium is less than 3.3 milliequivalents per liter, insulin should be held and IV potassium should be administered at a rate of 20 to 40 milliequivalents per hour till the serum potassium increases above 3.3 milliequivalents per liter. If the serum potassium is between 3.3 to 5.3, add 20 milliequivalent of potassium to each liter of IV fluid which is being administered. And if the serum potassium is more than 5.3, continue to monitor without potassium replacement until it falls below 5.3. And sometimes patients may also present with normal or elevated serum potassium levels, in that which case we have to check the urine output and consider for kidney status. Monitoring acidosis, the focus should be to correct the underlying disorder through the interventions of rehydration, insulin infusion, and potassium repletion. And correction of these factors will lead to an improvement of the pH without requiring any administration of bicarb. So it has got no role. But the treatment of hyperglycemia will decrease the ketone burden and the patient's bicarbonate will rise without any supplementation once this is corrected. So there is no therapeutic role of sodium bicarbonate for the correction of acidosis. So when to consider DKA resolution, as I already mentioned before, DKA is considered to have resolved when the blood glucose is less than 200 milligrams per deciliter and two of the following criteria are met. Either the serum bicarb is more than 15, pH more than 7.3, and anion gap less than 12. Absence of ketones may be delayed and it is not required to meet the criteria for resolution. But the Joint British Diabetic Society includes serum ketones of less than 0.3 millimoles per liter as a criteria. When the patient is able to tolerate oral intake, they should be permitted an oral diet if there are no other contraindications. What is the effect of this DKA on the fetus? DKA may directly contribute to fetal acidemia because beta-hydroxybutyrate can cross the placenta. So fetal heart rate racings, there will be minimal to absent variability, tachycardia, and late or severe decelerations. And there is resolution of this fetal heart rate racing abnormalities and biophysical profile within 24 hours of treatment initiation. So if the fetal status remains non-reassuring despite aggressive resuscitation of the patient, delivery should not be delayed. In cases of treatment of euglycemic DKA, if the patient has the blood glucose is less than 200, we have to correct it with 10% or 20% dextrose to avoid hypoglycemia. But other interventions, including insulin infusion, potassium correction, etc., remains just the same. During the post-DKA resolution period, the most important step after the DKA is to prevent recurrence. The underlying causative factor should be addressed. Infections such as urinary tract infections or abscesses should be ruled out and treated because they are the culprits which causes frequent episodes. And once the patient is able to tolerate oral intake, the nausea, vomiting should be appropriately managed. So this is the chart which shows the action plan in patients with DKA during pregnancy. As you can see, you have to send the labs, including serum glucose, serum ketones, CBC with differentials, serum electrolytes, bun creatinine, the anion gap, plasma lactate, etc. Initiate continuous fetal monitoring may take up to 24 hours for fetal heart racing to improve. Review the diagnostic criteria from the table, which I have mentioned at the beginning of this lecture, and initiate source workup as indicated, like blood cultures, chest X-ray, upper respiratory viral panels, sputum cultures, urine lysis, urine culture, etc. And the four main pillars includes the IV fluids to ensure a urine output of at least 0.5 mils per kg per hour, insulin to maintain serum glucose level at 150 to 200 milligram per deciliter, potassium targeting a potassium goal of 4 to 5 milliequivalents per liter, and correction of acidosis with pH more than 7.3. So my take-home message would be that pregnant women are more prone to DKA, particularly in their second and third trimester. Vigilant monitoring of diabetes in pregnancy is of utmost importance in avoiding the development of DKA. Absence of the typical clinical features of DKA, like nausea, vomiting, decreased level of consciousness, does not exclude the development of DKA during pregnancy, as euglycemic DKA is a known entity which has been very frequently found. Serum ketones and blood sugars should be checked in any diabetic patient during periods of illness to avoid missing the diagnosis of DKA, and rapid, appropriate, multidisciplinary treatment of DKA improves fetal and maternal outcome, and this can also avoid unnecessary emergency delivery. Thank you very much.